Mr. Weber is a leading healthcare policy consultant. His expertise lies in custom designing health plans which significantly reduce costs to employers and employees and reduce Obamacare compliance costs. He and a group of private investors founded MediBid, which allows patients to shop for medical care across state lines and international borders with full transparency. So please help me welcome Ralph Weber.
Okay, thank you. Thank you very much, and good afternoon, everybody. It's very, very good to be here. I want to thank Keith and Charlie and Jay for putting on this meeting. Very much needed. It's great to bring employers, employees, and doctors all together. And it's great to hear all of the different ideas and all of the people that are thinking the same way. So I'm very happy to be here. The name of my discussion for today in the program says changing the way we buy health care. The title here says medical care, so I wanted to start by talking a little bit about that. Can we go ahead and move to the next slide? What is the product? What is the product that we really are buying? For those of us in the room that are old enough to have turned on a high beam with their left foot, we remember the day when the product was medical care. You went to your doctor, sometimes you paid with chickens or with eggs. The doctor treated you. If you were hurt, if you were injured, if you were sick, you got treatment. It was medical care. Medical care is a service. It's very hard to leverage a service. Now, health care is a financial product. It's a financial instrument. It's no longer a service, and it can be highly leveraged. 1929, Blue Cross was formed by the Hospital Association to make sure that hospitals got paid better and to fill the beds. 1939, Blue Shield was started to pay the doctors. 1973, of course, the HMO Act, and then in 2010, the ACA doubled down on all of that. So let's think about some financial instruments that have had adverse effects. Subprime mortgage crisis, Lehman Brothers, Goldman Sachs, they created bubbles. This financial product that Adam was referring to, really the BUCA one, the fully insured health plan, is a product which is creating a bubble through the PPO networks, through the lack of transparency. And it's a product which increases utilization. And it increases costs. We can't control the cost of medical care if it's being driven by the product called health care. It's like a tiny little wedge pushing a big boulder. And it's increasing, and of course we have all these convoluted charge master allowable and paid prices. We have all these discounts and things like that. There's one word that I'm looking for to define the product called healthcare. If anybody can get that word, you'll get an autographed copy of my book.
Scam.
Good, but not what I was looking for. Not bad. One word. Who can think of the one word that defines the product? Go ahead, yell it out.
Irrational.
Well, yeah, that describes the product. One word. Jay? Anybody? What's the product we're buying? What do we buy when we buy healthcare? What do we buy? Access. You're getting close. You're getting close. They say it's access, but
You're buying good or service.
yeah, good or service. That's it. Who said coverage? There you go. I'll give it coverage. The product is coverage. Product is not treatment. It's not care. It's coverage. You're buying coverage. Originally being from Canada, where 96% of the people have coverage, but most people lack access. Okay? Buying coverage is not going to get you care. Let's go ahead and move to the next slide. The way we buy it now, how do we buy, this healthcare product now? I mean, I'm not talking about the TPA specially designed products. I'm talking, the fully insured BUCA type products, okay? We select a health plan. We pick a deductible, we pick co-insurance, co-pays, premium, stuff like that. If we bought cars this way, we'd go out shopping for a car loan. We get the car loan, we'd agree on the terms, then we'd go to a car dealer and we'd say, I've got this loan, what does this entitle me to? Okay? And the dealer would say, well, you know, the white Kia in spot P28. So we're buying an entitlement the way we buy health care now. We're buying a private entitlement. Again, it's designed to drive up the cost and utilization. The discounts, the artificial discounts, they're really interesting. A few years ago, I was negotiating a contract for a client, 5,000 employee group, it was a county, and they said one of the criteria which we will award this on is the amount of discount. So I went to the local hospital trying to negotiate a direct contract. And I said, I've got a group of 5,000 employees. I'd like to direct contract. What are your average discounts? And they said, well, you know, between 42 and 54. I said, oh, okay. What are your billed rates? Well, they're about 400% of Medicare. Okay. 400 less 50. Okay, it's 2. Okay. Can I get a better discount if I have a direct contract? They, oh, sure, no problem. And I said, well, what kind of discount could I get? And they said, what do you want? And I said, well, how about 75%? Sure, yeah, no problem. So I'm saying, okay, I got this one. And they said, now we're going to have to charge 800% of Medicare. Okay. So the discounts are artificial. The discounts are artificial. Artificial charge master, artificial discount, artificial allowable. Where's it all leading to? And it's because of the definition of the product. We'll go ahead and move to the next slide. The medical care has really become a byproduct. It's become almost an inconvenient byproduct. And of course, the BUCAs want the medical care to be more expensive and used more because they're making a little percent on every procedure. Not even to mention about the leakage in the PPOs. Initially, as I said, Blue Cross and Blue Shield were invented to pay the hospitals and to pay the doctors. But since then, they have become entities to pay themselves and the medocrats, the millions of medocrats in this country that just make things more complex. They don't add value. They don't treat people. All of the burdensome admin that the administrators have, that the physicians' offices have, that the insurance companies have, that Medicare and Medicaid has. I wanted to talk a little bit about the product as redefined. And the product is really, it's medical care. Samaritan Ministries is, Jed was out, okay, Jed. Samaritan Ministries, when their members go for care, they go for medical care. And if you look at their monthly shares, they've made it very, very affordable because they look for the product called medical care. With some of these BUCA health plans, some of the reverse incentives that drive up costs, like the annual cliff deductible. I was just talking at the Physician-Owned Hospital Association day before yesterday in Phoenix. And I was talking about direct contracting. And I said, the one thing that you have to do before you direct contract is you want to look at the provisions of the plan. You want to look at the plan document. You want to look at the ASA. You want to look at the plan design. As we see these deductibles increase, $3,500, $5,000, $6,000, $6,350, as we see them increase. And next year, when we see industries that traditionally haven't been covered, low-wage industries, people earning $7.50 an hour with a $6,000 deductible, their accounts receivable are going to be with the employee, not the plan. So I said, okay, if you negotiate a direct contract and you've got this huge annual cliff deductible, you're going to have AR. So you have to think about the price that you offer. The other thing that the annual cliff deductible does, it's September. My knee is getting really sore, and well, I haven't met my deductible yet, but my wife's having a baby in March. So I'm just going to wait until January because I'm going to go through my deductible next year. By then, a knee scope has become a full knee replacement. So it's escalated. And it's designed to do that. Also, once you use your annual deductible, you're all in. Once you're all in, you go all out. on medical care. So the BUCA plans are designed to increase costs. And that's why they have increased the cost of care. Let's go ahead and skip past the next two. Pricing. So how do we price medical care? Well, there's many different ways. There's a lot of leaders in this room that are really, leading the charge on pricing medical care. But really, ultimately, there are a couple of different ways. A couple of main categories, static and dynamic. The way we used to buy hotel rooms or seats on airlines, which is very complex. When you think about air travel, there are tens of thousands of destinations, hundreds of thousands of planes, millions of passengers. So how do you sell that before Travelocity? They had a rack rate, and then they had a few simple rules. Is the passenger under 12 or over 65? Are they booking 21 days in advance? Are they staying a Saturday night? Those were the kind of rules that each one gave a discount off of the rack rate. That's how we bought air travel. Travelocity and Expedia and Hotels.com, when you go online, the rates are dynamic. They're changing. Because they're based on occupancy rate. Actually, more specifically, vacancy rate. Okay? If you've got a hotel that has 80% of the rooms empty, you're going to get a better deal than one that has 5% of the rooms empty. Okay, it's based on vacancy rate. Why can't medical care be priced that way? Why not? It's not as complex as the BUCAs want us to think. It really isn't. We can be transparent, and I'm sure Keith's prices aren't the same all the time. They change from time to time. So we can have this. Now, let's go ahead and cue up film number 1, where I talk about transparency.
Did you know that the price of any given medical procedure can vary across town, across the state, by huge amounts? For example, colonoscopy. You can get a colonoscopy for $400. You can get a colonoscopy for about $6,500. And there's no difference, virtually no difference. 20 times difference in price, but no difference in the tools, in the training of the surgeon. No difference, but a huge difference in price. As a matter of fact, even within an insurance PPO network, it can vary by 10 times. There's this huge variance, but with no transparency. There's a lot of things about healthcare that people don't know. We're finding these things out, we're asking some questions, we're doing the work, and we're going to keep bringing these to you, because people have a right to know. Back 20, 30 years ago, you used to pay your doctor in chickens. He would tell you how much medical care costs. Have you ever wondered why you can't see the cost of medical care anymore? Reminds me of a story I once heard. Not sure if it's true, but it makes a lot of sense. 2 insurance executives, probably about 25 years ago, were having a meal in a restaurant. The first guy looked at the menu and he says, "Hey, there's no prices here. What's going on?" Second guy says, "Well, you know what they say, if they don't publish the prices, you probably can't afford it." The first guy said, "That just gave me a brilliant idea. This is fabulous. You're going to love this. How about if we hide the prices of medical care from patients? Don't let them see it. They're going to think it's so expensive that they can't afford it, and they're going to have to buy insurance. It's going to be a great way to sell insurance. What do you think?" Maybe that's how we lost transparency.
So for 2 generations now, since 73, we have been diseducated about the true costs. Okay? We've been told, no, you can't afford it. We're learning. I mean, most of the people in this room, I think, understand that, yes, you can. And we need to re-educate the public. Some of the recent interviews that I've had, the one was with publisher of Dell magazine, and I realized suddenly that the millennials are the ones that are going to drive the change, because they're not going to accept the status quo. Because they were born with a tablet, with an iPhone. They can research. They're not going to buy this lack of transparency. So the millennials are going to drive the change. And through trickle up pressures, they'll drive the rest of it. So the millennials, I think, are going to be a big key. Let's go ahead and move to the next one. The way MediBid works is really simple. It works with a self-funded health plan. Whether you have MediBid as a replacement for a network, an enhancement to a network, a first tier to a 3-tiered plan, or use it on a reference-based price. The employee logs on to MediBid, and if you have a reference-based price that has a cap or a reward point, they're going to see that number. They're going to see this is your either reward point or your cap for your procedure. And then they press a button that says create medical request. They make a medical request. Let's say it's for a knee replacement as an example. It gets sent to every orthopedic surgeon registered on MediBid across the country and overseas. And we have doctors in 10 countries. The doctors reply with a bid. Here's how much it's going to cost. Here's what's included. The employee will look at the doctor profile. They'll look at the quality. They'll look at the outcomes. And they'll make their choice. And they say, I accept. And then the auto reply comes back, when would you like to make your appointment? One of our patients that was interviewed on the Today Show about 11 months ago, Perry Hunt, needed a total hip replacement. He had needed it for a couple of years. This was, back during, a few years ago in California. He was really busy, and he owned a small construction company. He was told a THA had a 6-month recovery time. He couldn't take 6 months off, so he put it off. He put it off. He put it off. Finally, he couldn't take the pain anymore. And he said, okay, I'm going to get this done. So he was approved by Blue Cross. He was approved for surgery. And then the hospital called him 5 days before the surgery. And they said, listen, they're not going to cover it. For some reason, they're not going to cover it now. But if you pay right now, we're going to give you a 30% discount. So if you pay cash, we can still see you on Tuesday. So Perry said, well, how much is that? Like after 30% off, how much is it? $70,000. And he said, sorry, I don't have $70,000 plus 6 months to take off. So he found MediBid. He made a request. Within a day, he got a bid from India for $7,500. Then he got a couple from California for $14,000. Got one from Houston for $15,000. Phoenix for $12,000. San Antonio for $21,000. He accepted the highest bid for $21,000 because the surgeon said, I'm not going to be the lowest bid, but I perform a quality service and I perform a minimally invasive procedure with a quicker recovery time. And here's how I do it. And he explained, posted all his outcomes. So the patient accepted that bid. Some of the critics that follow MediBid, and Keith mentioned Marty McCary earlier, there's Marty McCary and there's Art Kaplan. They keep saying, no, in healthcare you have to pay more. You have to pay more to get more. I mean, who's going to go doctor shopping for the cheapest doctor? When I go to Hotels.com, I'm not always looking for the Motel 6. I'm not looking for the cheapest. I'm looking for the value. For this patient, there was value in paying more money to get a quicker recovery time. He was back on the job in 2 weeks, climbing ladders, lugging plywood. Okay, that was his value proposition. So value-based healthcare, looking for the doctor you want, looking for the procedure you want, is very important. Okay. Some of the people that have used us, one was a Samaritan Ministries member in Chicago, needed a colonoscopy. The best price he could find shopping around, $3,500. He flew to Oregon for a colonoscopy. Chicago to Oregon he got it for $800. Even after he paid his hotel and his room and his car rental, he still saved $2,000. We had a patient in Miami, needed a lumbar discectomy, went to New York, paid $14,400. Another one that we had needed a rotator cuff repair. He'd waited for years and years because he couldn't afford it. He shopped around for price. He was in Seattle. Went to Virginia. for rotator cuff. So people are traveling. They are traveling, and they are looking at the quality. They're looking not just at the price, but also at the quality. Another thing that people use us for is procedures that aren't available in the US, like HIFU for prostate cancer, hyperthermia for breast cancer, stem cell therapy for non-invasive knee replacements. People want these things, and they go online to find them. They want the value that it brings. Now, we had a first last week. We had a patient accept a bid. The patient is in Pennsylvania. He is traveling to Canada for hernia repair. Imagine that. We're sending Americans to Canada now. Okay. So I found it kind of funny, and NBC News wants to do a story on it. I'm not sure how they'll spin it, but it's a market. It's a market. It's growing, and it's something that only online technology can enable. People can search for the procedure they want. They can search for the surgeon they want. They can look for the quality. Let's move ahead here. I jumped ahead a little bit. Okay, one more. Okay, get back to that a second. When I was up in Nashville probably about 5 months ago, and I was driving towards Knoxville, and it's kind of a mountainous road. I went around the corner, and a car was coming the other way, speeding, swerving back and forth. And the driver leaned out the window and he yelled, "Pig!" And so I yelled some things back, which I won't repeat. He almost cut me off. And then as I turned the corner, go ahead and move to the next slide. What did I see in the middle of a road? A pig. So the signals he was giving me wasn't an insult, it was a warning. Okay? So we have to change the paradigm. We have to listen to the signals. We have to hear the warnings. The PPO networks, I feel, are in decline. We can't afford them anymore. People are starting to see this. They're starting to demand something better. They're starting to demand change. And the change is coming. We're going to see growth, well, next year, of course, when all these industries I talked about are going to have to provide coverage, we're going to see a lot of changes because a lot of people can't afford it. We're going to see narrow networks. We're already seeing them. Reference-based pricing. We're going to see medical tourism. All these kinds of things. There's a market for it. And there's going to be there has been a lot of change and innovation. This is going to continue. Let's go ahead and show the Fox Business video. This was an interview I did about 10 months ago.
Think about this. If you needed surgery, would you bid out the procedure to doctors and hospitals and other places in the country, people you had never met, just to save money? It's happening more and more because even when they say it's not, it's always about money. Sure, we all love going online to find the best deal, but usually you're talking about a hotel room, a flight, a television. Would you feel comfortable accepting an online bid for a hip replacement from a doctor you have never met? It is the newest wave in comparison shopping, and the website MediBid has made it a reality, giving people the chance to evaluate offers from doctors across the country and then travel to get the care of their choice. Here to discuss how it all works is MediBid's president, Ralph Weber. Ralph, what's the experience? I go online, what happens?
Well, you go online and you make a request. Now, it depends if you work for an employer that uses MediBid to source care or if you're just an individual. So you make a request and you can put in your parameters, a few health questions, your height, your weight, any medication allergies. You can put in how far you're willing to travel, if at all. And then you request a bid. You can review all the doctor's profiles, so you see where they went to medical school, what their training was, what their experience is, how many of these procedures they do every year. So you really get to see a lot about the quality of the doctor, as you make the request.
Wow.
which, with traditional insurance, I mean, all you know is in-network or out-of-network.
Yeah, you really don't know that much. I mean, although you are able to ask people in your community generally, especially if your community is smaller, then everybody sort of knows everybody. I have a lot of questions
Right.
about all that. Okay, so if I'm an individual, do I have to join and pay a fee in order to be able to go and look if my employer is not a member?
Yeah, if your employer's not a member, you can pay $25 just to make one request or join for $4.95 per month. And then $4.95 per month is a one-year commitment. And then you can go on anytime you like and make requests.
So, the biggest question I'm sure that everyone out in the audience has is what kind of doctors do you have on the network? I mean, does it include everyone? Is it just a small group? I mean, what percentage would you say of the doctors in America are available on your website?
Well, not a huge percentage. We look for doctors that are not the mainstream big box type of providers. Doctors prefer getting cash at the time of care. The traditional insurance model where they will charge one price, that's called the charge master, and then the carrier reprices it to the allowable, and then they're paid a portion of that. It sometimes takes 120 days or so for them to get their money. So the doctors like getting paid at the time that the care, and also they get to set their own prices.
Yeah.
With traditional insurance, they're told what they're going to be paid, and that's it.
No, that's interesting. They get to set their own price and see what the market will bear. A lot of our viewers tweeted in and said, it's very normal for people to travel to Sloan Kettering or to travel to MD Anderson for cancer treatment.
Right.
So they're familiar with the idea of traveling for big names. Do you have big names like that on your site?
Yes, as a matter of fact, we do. Baylor in Houston, MD Anderson is participating on a very small level.
Yeah.
We have talked to Curlin Job in Los Angeles. They kind of were looking at it. They haven't made a final evaluation. Yeah. So absolutely, we do have, we have overseas facilities too, like Bumrungrad in Bangkok.
Well, let me ask you about how some of the financials work. Okay, so say I get to, the doctor looks great online, I look at his, for whatever you can tell. I mean, I have the same problem when I'm kind of on my own health network and you're looking and you see their education, but until you go see them, you don't really know them. So say you get out there and you meet them or you see the hospital and you don't feel good about it. What happens then? Do you lose the travel money? How do the financials work?
Okay, well, I mean, if you've paid for your own flight, then yeah, I mean, you've had sort of a 2-day vacation, I guess, or whatever. I mean, it's not much different than if you looked in the yellow pages and went to MD Anderson or the local, corner hospital, either way. I mean, if you get there, you don't like the physician for whatever reason. Now, keep in mind, you've had a lot of transactions before you get to there. A lot of the doctors, when they respond to a bid, they'll say, okay, before we go through this, maybe we should have a phone call or talk on Skype or something like that.
Yeah.
So usually by the time you get there, you've actually kind of met the person sort of online.
And how does insurance play into this? Because in a couple of the articles that I was reading about this, they were saying that in some cases, your insurance company will pay for you to fly to another place if it is significantly cheaper for them. How do you get your insurance company involved in shopping for prices?
Well, a lot of people use private third-party administrators where they have more flexibility. And it has to be right in the plan document where it will allow. Some of the big carriers won't actually allow you to negotiate a better price without considering it out of network, which means you pay more of a deductible. So you have to make sure that your plan is set up to wrap around this kind of travel arrangement.
Yeah.
I mean, if you're getting a knee replacement for $21,000 versus $70,000, it would be foolish for the carrier not to cover. So it's with self-funded employers where they can do this, and they can save.
Yeah, what's the most common type of surgery that people are traveling for? What do you see the most? Because I imagine it isn't emergency surgery where people are price comparing.
No, that's true. Our app isn't quite fast enough to work in the ambulance. A lot of people are using knee replacement, hip replacement, colonoscopies. Those are probably some of our more common. Rotator cuff repair, we're getting a lot of requests for cosmetic procedures. But I think orthopedic would be the most common surgery because they're mostly pre-planned.
Yeah. No, it's a very interesting model because, of course, we're going through these dramatic changes in healthcare. People are trying to figure out, as they're forced to bear more of the burden of cost, how they can make it cheaper for themselves. Here in New York, a lot of, doctors have stopped taking insurance altogether and they've gone to all cash because the system is so hard to deal with. So an application like yours, I can see it gaining a lot of popularity as people, realize that they're really out there on their own trying to fend for themselves. Ralph Weber, great stuff. Thank you so much. Very interesting.
And it's not just about price, though, Melissa. It's not just about price. I mean, when you go to Hotels.com, you don't look for the Motel 6. It's about access, sometimes crossing a state line. A different medical board has different regulations which drastically can increase or decrease the cost. So it's about access and choice and getting the doctor that you want rather than the one that covers you.
Yeah, no, that's a great point. I'm glad you added that. Ralph, I think it's the wave of the future. Thank you so much for coming on.
Thank you, Melissa.
Up next, it won't be long before we are all driving iCars.
Okay, so that ambulance thing, that was one of my favorites. But redefining the product is the starting point. A lot of us in this room have done that, and we need to keep doing that. We need to emphasize what the product is, and then TPAs such as Kempton, Entrust can design products to wrap around that product, okay? And products that don't increase utilization, that take advantage of transparency and competition. I'm seeing some really hopeful things on the legislative front. A few states have written some bills. West Virginia wrote a bill a couple of years ago. It hasn't passed yet. It's been reintroduced. But it would allow their state employees to utilize medical tourism. And if they do, their travel's covered and deductibles are waived, etc. Okay? That's an interesting bill. The state of Florida wrote a bill that said that their state employees can use a medical bidding service and bundled case rates and bypass the Blue Cross network. So on the legislative front, even some of the states, even some of the governments are starting to realize it. So that's really hopeful to me. Employers are driving the change. They're demanding answers that were previously unavailable. And I hope we can bring a lot of employers into this organization and educate them and bring them up to speed. As we redefine the product and create solutions to work around it, we're going to see sort of a tidal wave of change. We're going to see this escalate. As we see people traveling, like I said, for colonoscopy from Chicago to Oregon, they're just saying, no, I'm just not going to take this anymore. Just like the old movie Network. I'm mad as hell and I'm not going to take it anymore. That's what we need to do. We need to say that. So we've got, good. 5 more. Okay, yeah. We'll just have a few questions for about 5 minutes if anybody has any questions.
I've just got a comment, Ralph. When we had our web design team make our website, and there are others in this room, did you use our guys?
I wish I did, but I didn't.
I know Dr. Bill Grant at the Monticello Surgery Center in Virginia used our website guys, but I had one condition, that I could change the prices from my iPhone.
Oh, yeah.
Because I said, eventually this will take off. I'll have competitors, and I need to be able to respond and do it on the fly.
Right.
And I've done that. I've done that on my iPhone. And the only other point I wanted to make, because your comment about dynamic and static pricing is, it's going to become more dynamic as more people enter this space. That's for sure. It's not real dynamic right now. But right. I have changed our prices in the last 5 years. Uh-huh. And in every case, I've lowered them in the last 5 years, except for some mathematical errors I made in the beginning when I had to adjust those. But there are only about 6 of those. We have 192 procedures, I think, online now, and more probably in the next 2 weeks. Great. But I compliment you particularly for making the distinction between dynamic and static pricing, because this is going to look really, really exciting as more people enter the space. So prices will just be changing. I thought right now is our slow time at the Surgery Center of Oklahoma. I mean, it's kind of a downtime, and Steve and I have joked about putting up a sign, bilateral myringotomy with tubes, half off, and actually show the price. Yeah.
Yeah, exactly. Well, thank you, Keith.
Show the price. Yeah, $800.
And that's the power of competition. It's the power, as competition increases, as you said, it's going to get more dynamic all the time. So absolutely, thank you. Thank you for making that comment.
Any other questions? Back here.
Mine's actually more of a comment than a question. I like the part of your talk that touches on the patient's value position. You know, the patient's not necessarily choosing the lowest price because they value certain things. And I think this touches on what we talked about in the last session about quality. One of the problems with quality metrics is that you're trying to objectify everything. You're trying to quantify it into digital features, and value and quality have a subjective portion. Different people value different things, and different people see quality in different things. You know, as a physician, we're trained to document our clinical encounters with something called a SOAP note. It's subjective, objective, assessment, and plan. And you ask any physician in the room, the vast majority of the decision-making comes from the subjective portion of the encounter. You talk to a patient for long enough and they will tell you what is wrong with them. You don't need all those tests. They help. You can confirm your diagnosis with that, but the patient will tell you what is wrong with them if you talk to them. And that's the problem with quality metrics, is you're putting everything into the objective box and you have eliminated the subjective portion of it. Quality is a satisfied patient. Quality is someone leaving your facility and going and telling their neighbor, they did a good job.
Right.
And you can't put that in a number.
Exactly. Thank you. One point I wanted to make, I'm asked a lot by the media, what if there are complications? And one patient that we sent to the Surgery Center of Oklahoma wasn't what they said they were. Now, our terms and conditions allow for, would have allowed Keith to say, hey, listen, something else has come up. I wasn't expecting this, so it's going to be a little bit more. But Keith said, you know what? I make money on some. I lose money on a couple. I'm going to take care of it. It's taken care of. So the way Keith sets his prices allow for that. Okay? So that's an important thing also. In regards to quality, we thought about getting together with like a Leapfrog or Health Grades, but what I find is that they have more negative review. The happy people, they don't go and post the reviews, So it's sort of skewed. We do, not interview, but we survey every patient that completes a procedure through MediBid, and we ask them 5 simple questions on a scale of 1 to 5. That was the bedside manner, professionalism of staff, was the outcome what you expected, just those really simple questions, and we categorize them. And if there are ever really, really low ones, we'll act on it right away, okay? But we do monitor that going forward. We just haven't, I agree with you. We haven't figured out the perfect way to post it.
We have time for just one more. Yeah.
Ralph, I wanted to put this to you and anybody in the room that might have experience with it. One of the problems we run into is dealing with in-network patients, those that still have third-party contracts. And how do you deal with cash or a discounted services that's below, what your in-network contract might give you? And one thing that some of the folks in my area have come up with is they submit the claim as paid in full. In other words, if they're going to get $750 in 2 months for a procedure, or $500 today, they take the $500. Even the patients in network, they take the $500. They submit the claim paid in full, and therefore they really haven't violated their agreement. So what is your take on that?
Well, if you are dealing with a cash patient, then just don't code it. Don't put a CPT. Maybe if it's a bundled case rate, maybe it's a global rate, because then you're not violating the PPO contract. You can say, this wasn't a 66070. This was a bundle. It was a few different things. I bundled this. Now, if you have to, do the CPT codes, then it's a little bit kind of touchier. But by bundling, you can sometimes get around that. But maybe there's somebody else that has Ed?
I think it was to keep, so the folks can keep track of their deductible and kind of
Right.
One of the ways around it.
Ed, you want to make a comment?
You know, a lot of people have automobile insurance, hopefully mostly everybody in this room. But if you ding my car door, you may choose not to use that insurance. And I've experienced, I had, and I'm going to go through the blood details, but I saved 65% off of the PPO discounted price. The numbers were 11,300 billed, 7,700 after the PPO discount, cash price 2,700 all inclusive for replacement of a right lens for a cataract. And it was an interesting discussion because they had verified benefits and we had the First Health Network. And I said, do we have a cash price? And they said, but you have insurance. I said, I know I have insurance, but I pay for it. It's mine, and I choose not to use it. Do you have a cash price? And they said, yes, we do. And I took advantage of the cash price because I looked at the differential. So I would challenge any PPO contract, all right, in a court of law that says, wait a second, I'm paying the PPO through my insurance to get a discount, but I choose not to use it.
I think the concern was on the physician side, whether we were violating.
The PPO never knows about it.
Right, yeah, right.
Well, thank you, Mr. Ralph Weber.
Thank you.